Good evening, everyone. A warm welcome once again towards the International Lecture Series on Clinical Nutrition. Thank you all for joining us today. And today's session is going to be on renal nutrition, enteral nutrition in renal conditions. Now, chronic kidney disease, as you're aware, it's a progressive disease that affects more than 10% people worldwide. Yes, thank you. Yeah, sorry. Chronic kidney disease, as you're aware, it's a progressive condition that affects more than 10% of the general population and affecting more than 800 million people around the world. It is more prevalent in individuals that are older, women, and racial minorities such as the Southeast Asian, African population, and people from the Latin America. It is also seen more in people who have other non-communicable diseases like diabetes and hypertension. More so, it is seen in countries that are low and middle income groups. And we see an increasing prevalence with increasing prevalence of non-communicable diseases as well. It is one of the leading causes of mortality. And nutrition has a very big role to play in not only preventing renal diseases, but managing, treating, and ameliorating the different metabolic abnormalities associated with renal conditions. So today's session is going to talk about different aspects of renal nutrition, and it's going to pique your interest in that area. But before we begin with the session, let me just reiterate the rules and regulations. The certificate of attendance for this lecture series will be given for all those who attend all 10 sessions, followed by an objective test. Attendance for the complete session is mandatory for all sessions. The objective test will be a 100 marks test that will be given via Google form, which will be sent to you on 1st of March 2023. Minimum 80% attendance is required, or 80% passing mark is required to pass the test. Feedback for all sessions is mandatory. The feedback link will be posted at the end of the session in the chat box. It will also be emailed to you. Questions can be posted in the Q&A box and will be taken during the panel discussion. All comments, suggestions, and any other aspects that you would want to kind of communicate to us, please post that in the chat box so that the questions can be separated from the comments and suggestions. Those attending from the YouTube link will not be eligible for the certificate. Now, with this, I take pleasure in inviting our expert for the plenary session on enteral nutrition for renal conditions. Ms. Zamrud Patel, she's a well-known face in the arena of renal nutrition. And she's an expert with many, many years of experience in renal nutrition. She's currently the Chief Dietitian of Global Hospital Mumbai, chapter convener of Indian Dietetic Association Mumbai chapter. And she has various publications in the nutritional guidelines from chronic kidney disease and renal patients. She's also published several books for patient education and recipes for renal conditions. So I welcome ma'am to deliver her lecture on enteral nutrition for renal conditions.
Thank you, Sukhuda, for that kind introduction. I will start with my screen sharing. Can you see my slides?
Yes, ma'am.
Yeah. Okay. Okay. So today's topic, we will be covering enteral nutrition for various renal conditions. Basically, when we talk of enteral nutrition, it is more focused for patients having being in a critical care setup where enteral nutrition is a must for them. Enteral nutrition in conservatively managed people where only diet is advised and who have a chronic kidney disease is also used, but its use is limited. Probably we use this enteral nutrition in that population when they are really malnourished and we need to build their nutritional status, either when they are going towards transplant, that is end stage of kidney disease. Enteral nutrition we have also been using in pediatric population because children don't eat well with the given restrictions for the renal patients, specifically the salt part. So just to start the topic, we need to understand the normal function of the kidney. Now, kidney is like this that what we call the organ which removes the nitrogenous waste products which are produced from the protein metabolism. It also maintains the fluid, electrolyte, and acid-base balance of our body. So it not only an excretory organ that functions that it performs, but it has important functions because it produces renin, it produces erythropoietin, and it activates vitamin D in our body. So if you see a patient of kidney who has a kidney problem, probably so you find that the hemoglobin is low. That's because erythropoietin is not synthesized by the kidney. You find that their blood pressures go uncontrolled because renin is missing. And again, they have bone problems. That is, they have problems, bone pain and all. So that is why you need to give the diet pattern in such a way that all these functions can be taken care from the diet. So you need to give a diet which has to be lower in protein when we are talking of chronic diseases. But we are talking today of enteral nutrition in critical care setups, and you will find that here we are not going to be giving a low protein diet, and I will be explaining so why in the further slides. So when we talk of kidney damage, what are the types of damage that one has? So you have acute kidney injury where there is a sudden problem to the kidney. Okay, and because of that, the kidney, you find that the serum creatinine suddenly increases. But this is a condition which is completely reversible, where a person recovers. So you need to understand here that we use enteral nutrition more in this population having acute kidney injury. Okay, the second type of damage that the kidney has is a chronic damage where there is a slow and progressive damage that happens to the kidney, and probably this is the population where we try and use low protein diets to control the progression of the disease. So if you have to look at the nutrition, how do we follow in this acute kidney injury patients? These are hospitalized renal patients. You need to do a nutritional screening and assessment. But mind you, many times you may not be able to do this because the person comes with an acute element. He has other challenges. He may be in an ICU setup. So you need to do a nutrition intervention immediately. The first tool that we always use is if the GI tract is functioning, use it. But if it is not, the person is really very sick, then probably you need to think of parenteral nutrition. Otherwise, we always aim for enteral nutrition. Okay. And in some people, sometimes we use a combination of both enteral as well as parenteral nutrition. Now, when we talk of enteral nutrition, normally what we are taught in critical care setups is that when in a critical care patient, you can use the polymeric formula. But in such cases, we try and use renal specific formulas. And we keep monitoring and adjusting their diets, their enteral nutrition patterns that we use regularly. It is not that today we plan something and that will be continued throughout. As per their biochemical parameters, you need to keep adjusting their diet plans accordingly. Now, coming to what exactly you see in the stages of chronic acute kidney injury. Sorry, I'm so sorry. So we normally have in 3 stages. Okay. Normally today what we will be discussing is the stage 3 where person needs dialysis and enteral nutrition is a must. So normally in the first stage you will find that there is a rise in creatinine. So normal creatinine is about 1. So there is a small rise in creatinine of 1.5 to 1.9 and the urine output becomes less than 0.5 ml per kilogram per hour for 6 to 12 hours. In stage 2, you find that the creatinine will be about 2 to 3. And again, this urine output is dropping for more than 12 hours. And stage 3 is somewhere where really you need to start renal replacement therapy where the serum creatinine is more than 4 and the patient may not have any urine output. Okay. So this stage is the one where enteral nutrition is started and you need to be planning the diets depending upon what is the stage of acute kidney injury. Now, mind you, when you are in stage 1 and 2, the diet restrictions may not be very stringent, but in stage 3, the diet that you give is going to be based because the person is going to need a renal replacement therapy. Now, when there is acute kidney injury, you need to understand that there are a lot of metabolic changes that happen in the body. The carbohydrate metabolism gets affected, the protein, the lipids, the major macronutrient metabolisms get affected. Micronutrient deficiencies, you will see there could be multi-organ failure, there could be sepsis, there could be trauma, and all this accounts for a good nutrition for this patient. So when you are treating a patient of acute kidney injury, you really need to focus on the nutritional status and plan the dietary pattern. Okay. Now, there are other factors also which contribute to protein catabolism in acute kidney injury. And I'm not going to into the detail, but one thing that we need to understand, when you have a patient on acute kidney injury, the most important thing that we need to remember is that you need to feed your patient very well, and he may be given renal replacement therapy till the time the acute element is treated and his kidney function starts normalizing. Okay, so that's very important for us. Now, this is just to show you the stages. You have pre-renal, intrarenal, and post-renal. Now, these are the AKI stages that we normally see. These are the basic causes because of etiological factors. Now, when it is a pre or a post-renal, the dietary changes may not be much. But when it is intrarenal AKI, this is the most severe form of injury that happens to the kidney, and the nutritional requirements may be altered at this stage. This is again to show you that, when you're trying to read the papers, you need to understand that what is the cause of AKI, whether it is pre-renal, it is post-renal, or it's intrarenal. That's very important for us to know to plan the dietary prescription for the patient. Now, I've already told you that there is alteration in carbohydrate metabolism. AKI is characterized by hyperglycemia due to peripheral insulin resistance and accelerated hepatic gluconeogenesis. So basically in AKI, you will find that the sugars get deranged. The lipid metabolism is also affected because you will find that there is basically more amount of lipids in the blood. So when you are planning your diets for these people, when you're using the formularies that you're going to, scientific formulas for the enteral nutrition, you need to have a formula which will not give direct sugars or which is not very high in lipids. But that's the reason when you're treating people with AKI, you need to think of renal specific formularies, okay, to plan their feeds. Now, there are different types of dialysis we use when a person has acute kidney injury. So we are not doing a session on dialysis, but this is to just bring it to your notice that you use peritoneal dialysis, you use IHD, which is intermittent hemodialysis, you have SLED, that is sustained low efficiency dialysis, or you use CRRT, that is continuous renal replacement therapy. Now, whichever type of dialysis is used, you will find that when you're calculating the calorie and protein requirement of the patients, you will find that there could be a minor difference. So when you are planning, you need to understand this, that if the person is on continuous renal replacement therapy, maybe the protein requirement will be slightly more compared to PD or IHD or SLED. Okay. So we will be discussing this in little detail in further slides. Now, nutritional requirements. Ideally, if you need to calculate the nutritional requirements, indirect calorimetry is the gold standard method that you need to use for calculating the energy requirement. However, indirect calorimetry is not easily and widely available in most of the centers. Hence, what the guidelines have told us is to use 25 to 30 kilocalorie per kg body weight for critical ill patients. Okay. And now if you see over here, protein requirement ranges from 0.8 to 1.5 grams. Now, why is this protein ranging from 0.8 to 1.5 is, if you are managing your AKI patient only on dietary management, that is a conservative management, no intervention, that means there is no renal replacement therapy used, the protein intake will be calculated between 0.8 to 1 gram. But if there is an intervention renal replacement therapy used, then the protein requirement would range between 1.2 to 1.7, not 1.5, depending upon the type of replacement that is being used. So there is a wide range in the protein requirement. Now, so when you are trying to balance out the protein, where would the energy come from? So it would come from the carbohydrates and lipids. Okay, enteral route is always preferred over parenteral. That's what we always say. If the gut is working, use it. Time to initiate parenteral depends on underlying nutritional status. So if you have to use parenteral, probably if your AKI patient was already malnourished, you're not able to achieve your targets in 3 to 5 days with enteral nutrition, probably a partial parenteral nutrition may be needed. And macronutrient requirement would depend upon the type of renal replacement therapy that you are going to be using. Okay, so probably if you find there are very limited studies which show that how much electrolyte, how much vitamins, and how much minerals. So probably what we normally do is we do the serum values of these nutrients, and depending upon that, we try to adjust the enteral formularies that we use. Now, micronutrient requirement is poorly studied in AKI. Trace further the effect of renal replacement therapy on removal of mainly protein bound trace elements are far from clearly defined. But you do see that you do need to give them vitamin C, folic acid, thiamine, selenium. You need to add this to the enteral formulary and sometimes even give it externally. So you discuss it. So whenever there is a patient of acute kidney injury, it's a team approach that we follow to plan the nutritional status. So medical management, the doctors tell us, nutritional management we put in, and the nursing team is always with us to reach and to provide the nutrition that we are planning so that they can administer the feeds to the patients. Again, phosphorus, magnesium, all these depend upon the patient requirement. Now, fluid balance is always crucial aspect of managing patients with AKI. Very often you find that people are in overload, and that is why you need to be in regular touch with your intensive care doctors so that you can discuss how much fluid needs to be given to the patient to avoid the patient to be staying in large positive balances. So you need to understand what are the medicines that are going to go through the IV, how much fluid is going to go from the IV, and how much is going to go through your tube feed. Again, you need to also understand that we are saying that when the person is on renal replacement therapy, we say that there are losses of nutrient. But it is not that everything is lost on renal replacement therapy. Sometimes you do have an energy excess provided by the citrate, lactate, and glucose, which is used in the renal replacement therapy solutions. So you need to factor this, and you need to see that the patient is not overfed or they do not have a hyperglycemia. So normally the range that you have to see when you are placing your patient on enteral nutrition, the range for the sugar has to be between 110 to 150 milligrams per deciliter. Okay. Now, as we've already spoken, time and route of feeding. Early enteral nutrition is recommended. That's very important. Early you start feeding the patient, better is the outcome. And all the guidelines have been saying this to us. Early TPN, that is within 48 hours, in case enteral feeding cannot be established, is only in ISPIN recommendation. Okay, not in other recommendation. ASPIN recommends it on day 8 in case enteral cannot yet establish or provide the recommended nutrient that the patient needs. This is not true for previously malnourished patients where TPN is early recommended. So if your AKI patient is malnourished, probably you may initiate partial TPN early, but in general, guidelines do not recommend its use in routine. Ideally, the route that is recommended is enteral nutrition. Now, coming to the calculations when we are talking of the requirements, okay, so you need to understand that there is AKI. If there is AKI, acute kidney injury, and no renal replacement therapy is used, then 20 to 30 kilocalorie is what we need to use for the energy requirement. Okay, that you need to understand, and this is for the protein requirement. So when there is AKI and no renal replacement therapy is used, 0.8 to 1. This is what I just told you. 0.8 to 1 gram of protein you need to give your patient. But when there is AKI and there is renal replacement therapy that is used, the energy requirement still remains the same, 20 to 30 kilocalories, but the protein requirements increase from 1 to 1.5 gram of protein. If there is continuous renal replacement therapy used in the form of CRRT, the protein requirement becomes about 1.7 grams. Ideally, when we are doing our calculations, we try and use ideal body weight in our setup. Okay, so that's very important. So if there is AKI and no renal replacement therapy, then the protein will be lower. But if there is AKI and renal replacement therapy, then the protein requirement will increase. Okay, that's very important to understand. Now, this is another, just to show you a paper which also states that in acute kidney injury, nutrition support should be started early and there should be adequate intake of proteins because there is healing that needs to happen. Again, if you are not able to reach your requirements through your enteral, then probably you need to work on parenteral. But ideally, we are able to reach our requirements using enteral nutrition, and that is why parenteral may not be needed in our population. Now, when you have to calculate the energy requirements, you can use the the energy requirement by basic energy. You can calculate using the Harris-Benedict equation. This is the equation that is that, or probably if you are looking at the guidelines, it says between 20 to 30 kilocalories. A factor of 25 kilocalorie per kilogram body weight you can use to calculate the energy requirement. Protein, I have already stated, the requirement would vary from 0.8 to 1.5. There are studies that show that average protein catabolic rate is about 1.5 gram of protein per kilogram, and RRT induces further amino acid and protein losses, and that is why when RRT is used, renal replacement therapy is used, about 1.4 to 1.6 grams of protein you can use to calculate your protein requirement. Okay, so you need to give when you're planning these people's diets, enteral formularies, we use scientific formulas, we try and use renal specific formulas, and we use for energy requirement a factor of 25 kilocalorie, and protein would be about 1.5 grams. Okay. Again, this is just when you provide adequate energy intake, the protein will be used for the right purpose. But remember, you do not provide extra calories because that will cause hyperglycemia. But you do need to give adequate amount of proteins. So, just to summarize over here, you need to understand that better feeding and good dialysis is very important for AKI patients. If you have to start immediately, if you see guidelines, they very clearly say that standard enteral nutrition formulary you can use for your patient having AKI. But what we have been using and we found it very useful is to use renal specific formulary because they have a balanced amount of electrolytes, they have a balanced amount of calcium, phosphorus, where the metabolisms get affected. So it's very important for us to use the renal specific formulary, scientific formulary for our patient. Protein should not be restricted in this population because normally the concept is that the person has a kidney problem, reduce the protein intake. That is true for chronic patients, not for acute patients. For acute patients, renal replacement therapies are used. They have other challenges for which you need to provide good nutrition. Adequate calories with adequate amount of protein is very important. When you are calculating the protein requirement with people who have renal replacement therapy use, you can use up to 1.7 gram of protein. So do not hesitate to increase the protein content of your feeds. In case of significant electrolyte imbalance, definitely this will not happen if you are using renal specific formularies. That's very important for us to understand. Okay, when we use these type of formularies, we are planning the tube feeds accordingly. We do a calculation of our electrolytes from, because we are using scientific formulary, it becomes very easy. When you do the blood parameters of your patient, you see the electrolytes, the imbalances are not very common. So when you start the feed, probably a standard polymeric formula may be needed, may be used. But when you are actually doing it for a specific case present there, see the biochemical parameter, discuss with the doctor what is the mode of renal replacement therapy that will be used. Based on that, you do your calculations for calories, for protein, use a renal specific formula and plan the patient's diet. That's very important for us. Now, this is as far as the renal replacement therapy in acute kidney injury is it was for whatever I have discussed. Now, when you have people with chronic kidney disease, there are some modifications that one needs to be using for this population. Now, when we are using them, what you need to understand is the common restrictions that we use. See, calorie and protein we have discussed. Calorie would remain between 25 to 30. Protein you will restrict to 0.8 gram if it's a chronic kidney disease patient. But you need to talk of modifications for electrolytes and fluid overload. Now, when your patient has hypertension and fluid overload, what do you need to work closely with your patients with? So if you see the recommendations say 3 to 5 grams of salt, not sodium. This is salt recommendation. 3 to 5 grams of salt, no processed food in the patient's diet. This is talking of the oral diets for the patient. And all high sodium foods should be restricted. So this you need to understand. Okay. Now, when you are restricting the salt intake of the patient's appetite reduces. How do you increase the appetite? How do you make the food tasty? You make the food tasty using flavors like lime juice, like vinegar, kokum, you have tamarind pulp, you have dry mango powder, you have spring onion, you have ginger, you have garlic, you have mustard powder, cinnamon powder. These are the natural flavors which are available. So if you add this to the patient's food in limited portions, you will add flavor without increasing the electrolytes of the patient's diet. But for this, you need to work very closely with your patients. When you work very closely with your patients, only then you understand what is their requirements. Okay. Now, lot of people think that when you are restricting the salt, you can use salt substitutes available in the market. Mind you, for kidney patients, you cannot use salt substitutes. The reason why we cannot use salt substitutes is because they are potassium-based salts. And these people, the other electrolyte that is impaired for patients of chronic kidney disease is potassium. So the salt substitutes which are known as Lona, diet salt or low salt, which are available freely in the market, should not be used. Your salt prescription also needs to be individualized for the patient. It is not that the guidelines are saying that you have to use a 3 to 5 gram of salt. There may be some patients who have anasarca and you may have to give them a zero salt diet. Okay, I'm not talking of sodium, I'm talking of salt. Okay, so you need to make your prescription individualized for your patients. You should not have a common prescription, right? Now, today in the market, you have low sodium salts also available. Now, for our kidney patients, we should not be using even these salts because here the sodium content is reduced to 15 to 30%. But again, when you see the nutritive value, here again potassium is there, and here these salts are not low in sodium really. Only 10 to 15% of the sodium is lower. So your regular sodium content of the diet is about 336 milligrams. Here it is, 36 milligrams, I'm sorry. and here it is about 33. So it's not a big difference. Again, when these salts are prescribed to the patients feels this is low in sodium, I can use as much as I want. It is not so. When these low sodium salts have to be given to the patients, even that prescription needs to be given to the patient, because how much salt they are supposed to use depends upon your calculation as to how much sodium you are allowing in the diet. Whether you're giving a mild restriction, whether you're giving a moderate restriction, or whether you're giving a severe restriction. So, for example, I had a patient where I had used a severe form of sodium restriction where the total sodium content of the diet was less than 800 milligrams. So that was equal to 2 grams of salt. So the visible salt that we gave was only 1 gram, and the invisible sodium that was coming was around 400 milligrams. So even when you're using these low salt products for your patient, low sodium products for your patient, you need to ask your patient to read the label well, make him understand that these are lower, but they are not free foods for them. Okay, here also the right prescription needs to be given to them so that they are not going overboard and using too much of the salt in their diets. Talking of the second more important modification is when the potassium levels are high, hyperkalemia. So if your patient has a serum potassium above 5.5 milliequivalents per liter, you need to give a low potassium diet to your patient. Now we have the new IFCT book in India, which we are referring. And as per that book, we have 4 low potassium fruit. It is apple, papaya, pear, and pineapple. So you have AP3. Okay. So that are the low potassium food. So when your patient has a high potassium, probably you need to give low potassium food. Then how do you need to train your patients at what are the high potassium foods. So your coconut water, fruit juices, soups, these are high in potassium. The other fruits are high in potassium. So you need to give a list to your patient. What are the high potassium food? And you need to train your patients that how to leach the potassium. So when you take any vegetable or dal, you wash it well, you put generous amount of water, you boil that dal or the pulse or the vegetable, you allow that potassium to come into that water, switch off the gas, drain the water out. Okay, that will help in leaching out the potassium from the food. Now, apart from that, people are used to tea and coffee. So probably you can use milder versions of tea and coffee in the patient's diet. When you're using flours, tell them to sieve the flours because in the outer husk, the potassium is more present. So when you sieve and use your flour to make your chapati, you are reducing the potassium content of that food. So leaching is a very important thing that we need to train our patient. Talking of high potassium and low potassium foods with them is very important because when we do this, our patients will be able to make their diets more palatable with the given restrictions. And again, I wanted to highlight one more important thing, that how do we assess the protein intake of our patient. So when we have to assess the energy and protein intake, we normally do it from the diet diaries or the diet recall. We see how much the patient is eating, what is the raw ingredient that is gone, and from that we calculate the energy and protein requirement. But in patients of chronic kidney disease, where we really need to focus on the protein intake, we can use a very good method, objective way of assessing the baseline protein intake of our patient by using the 24 hours urinary urea nitrogen. Now, you have to do a urine collection for the patient for 24 hours. Ideally, for a stable patient, the nitrogen intake will always be equal to the nitrogen loss. So when I do a 24 hours urine collection and I calculate from that collection the nitrogen loss by doing a 24 hours urinary urea nitrogen from that sample, and I can calculate for the extrarenal losses by using a factor of 0.031 into weight in kgs. Now, 1 gram of nitrogen is equal to 6.25 grams of protein. So whatever is my nitrogen loss that I get from this 24 hours report, if I multiply it by 6.25, I can exactly know objectively that what is the protein intake of my patients. This is very important for us dietitians to assess, because many times the patients are not able to recall and tell you exactly what they've eaten. Many a times they eat food which is prepared by a caretaker, and that caretaker may not be available to tell you what exactly he's added in that food. Okay, what are the other ingredients he added? So if I do my calculation from this 24 hours urine sample collection, and I can calculate the nitrogen loss, I can very well know what is the protein intake of my patient. Once I know the protein intake of my patient, I can think whether I need to give a restriction or I need to add proteins to this patient's diet. So this is one of the papers which we had written, which gives you how to practically. We have probably given the plans over here and some recipes over here for low protein diets. And one thing that I want you all to remember is that disturbances are variable and diet needs to be individualized. Whether you are doing a tube feed, enteral nutrition, or you're doing oral diets, you need to individualize the prescription for the patient, and regular monitoring and is very important to get the compliance. That's very important for us to assess. So thank you for your patient listening. These are some of the publications that I have for my patients education that I have published. So thank you, and I would be happy if there are any questions to take those questions. I'll just stop sharing so that we can take this session ahead.
Thank you so much, ma'am, for such a wonderful session. A renal diet is not a simple low sodium, low electrolyte, low protein diet. There is a lot to think about, and you need to individualize the electrolyte and protein intake for the patients. A renal diet also needs to think about the quality of protein, and sometimes there could be limitations in terms of the fluid intake for the patient. As renal dietitians and nutritionists who specialize in this field, probably we need to think of limiting the restrictions so that the patients can have a better quality of life. So thank you so much for putting that message across. We will take the questions in the panel if that's okay. We have a lot of questions pouring in. So
sure.
Yeah. May I request all the panelists to please switch on your cameras, and we can just quickly introduce all the panelists. So our panel discussion is going to be regarding nutrition in different renal conditions. So we're going to take some of the questions from the audience members, and let me just quickly go around and introduce all the speakers. So you're already familiar with Ms. Amrit Patel. You've heard ma'am's wonderful talk just now. We are also joined by Ms. Yovani Virappan. She's a consultant dietitian with All Good Limited, Mauritius. Her main area of interest is renal nutrition, eating disorders, and IBS, and she also holds an MBA as well. So she practices in Mauritius. So welcome, Ms. Yovani, from all the way from Mauritius. Our third panelist is Dr. Shamim Tumuhaise. She is working as a nutritionist with St. Catherine Hospital in Kampala, Uganda. And she's worked in various settings, right from the community setting where she worked with malnourished patients with F75 and F100 kind of interventions. She's also worked with FTP in providing the food and cash beneficiaries to the right entitlement as well. So we welcome you, Dr. Shamim, as well. Our next speaker or panelist is Ms. Shaila. Welcome you from all the way from Bangladesh. She's a chief dietitian at Asghar Ali Hospital, Concern of City in Dhaka. She's worked in several different hospitals and also as a guest lecturer at a nursing institute, Women's Medical College in Uttara. She holds an MPhil in nutrition and food science and has experience of more than 11 years on the clinical side in critical care, weight management, diabetes, etc. And she's an EC member of Bangladesh Nutrition and Dietetics Forum. So welcome, Ms. Shaila from Bangladesh. And we have our very own Ms. Sunita Rao from Bangalore. So welcome, Ms. Sunita. She's an RD and Chief Nutritionist at NU Hospital, Bangalore. She's the Secretary of the IPIN India Bangalore chapter, over 15 plus years of experience, and Joint Program Officer of IPIN India Renal Core Group. She's also an Executive Committee member of IDA Bangalore chapter and has various certifications and courses such as SPIN and LL, etc. to her credit. She's also co-authored various books on renal recipes and other friendly recipes for CKD patients. So welcome, Ms. Sunita, to the panel. I'm trying. Ms. Shamini, may I request you to join the panel as well? So if we can just quickly start with where ma'am kind of ended her talk. Ma'am, I'll start the question with you. Is protein supplementation really important for people with kidney disease? Can we give high protein diets to people with kidney disease? You've covered that extensively, but that question has come in from the audience. Is it really safe to use high protein foods or formulas in kidney patients?
So you need to understand that how you are managing your patient of chronic kidney disease. If it's an acute element that the patient had, it's an acute injury on chronic kidney disease, yes, you can use high protein supplement. You have various renal specific high protein supplements which you can safely use in this population. But if you are conservatively managing your patient of chronic kidney disease, then the protein intake needs to be restricted to 0.8 to 1 gram. Probably I would say it depends case to case. If you have a malnourished patient or a vegetarian patient who is not eating well, probably I would want to go up to 1 gram of protein. I may use a supplement if his appetite is not good. Okay. But yes, if my patient is eating very well, he has a progressive disease, there is nothing else, there is no acute element, then probably I'll think of restricting the protein intake between 0.6 to 0.8. I may not use a protein supplement for the patient. That's what I want.
Okay. So, ma'am, like rightly said, patients who are on hemodialysis may require higher protein as compared to ones who are not getting any renal intervention. So, Ms. Sunita, my question is to you. Generally, these protein foods will have a very high phosphorus content as well. So, how do we tackle that imbalance for these patients?
Right. When the patient is on hemodialysis, they do require a stepping up of protein intake. Now, if the patient is on enteral nutrition, like just how Zamrut was talking just now about enteral nutrition, for a certain segment of patients who are not orally able to feed, then there is no problem at all. In that such cases, we have renal specific nutrition formula where the protein content can be delivered without increasing the electrolytes, neither the phosphorus nor the potassium. But then for the population who are on a regular diet or they're eating normally, it becomes a little challenging. The first line to do would be to remove the inorganic sources of phosphorus that come from the processed foods, because these contain those chemical salts in the form of phosphorus that are absorbed almost 95 to 100%. So first line of elimination would be that. And then when you're introducing the animal protein, you have to look at the phosphorus protein ratio, where the egg gives us the best advantage. So egg whites, I'm sorry, it's not egg, but the egg white, where the phosphorus content is very low and they deliver good amount of proteins. When you look at chicken and fish, when you compare them, the fish fares better. So when you plan the entire day or a week's diet for your patient with the amount of protein that is required, if you include all these points and make sure that you avoid inorganic, then introduce good amount of eggs, and then you give a fish in greater amounts compared to the other non-vegetarian sources, that would help. And then when you are giving in vegetarian sources, if you remove the bran, excess bran, because most of the time the bran will have the higher phosphorus and the potassium content. So phosphorus gets removed if the bran of the food is removed. So overall in a diet, then you can reduce the phosphorus from the bran. Having said that, actually the amount of phosphorus absorbed from plant sources is the least. So this is how you plan for hemodialysis or peritoneal dialysis.
Thank you, Ms. Sunita. So a lot of the renal diet will also involve in counseling the patients how to process the food that they're going to eat as well. So how they process or cook the food that they're going to eat.
Yeah. Even cooking reduces phosphorus for that matter.
Correct. So that brings me to a point, Ms. Yovani, this question is for you. What are some of the metabolic alterations that you see in end-stage kidney disease? And is that really manageable with the help of a diet?
Yes, thank you. Well, as well presented by Ms. Patel, as we have seen on the slide previously, effectively, when you are on the end stage kidney disease, there's lots of metabolic changes. So you will have changes like the patient might be suffering from severe anemia. You will be having, all the organs, multiple organs failures. If the patient is not being assisted properly by a dietitian, definitely the patient will be completely lost with the electrolyte management. You might end up with someone with hyperkalemia, which is really dangerous. So it's a lot to do. So definitely, yes, there's lots of metabolic changes happening, and we have to follow them really carefully. And that's the reason why, especially here in Mauritius, I can see in India it's completely different, because you are really, like a whole team of dietitian. But here we don't have enough dietitian, and renal patients are not being assisted by, dietitian. It's basically the doctors who are giving just a few advice randomly, and they are completely lost. Yeah.
Thank you so much for that, Ms. Yovani. Ms. Shaila, just adding to that, you do see a lot of high, the blood urea nitrogen or creatinine that increases. Can diet really help in reducing this? So can uremia be managed and decreased with diet? You're on mute, Ms. Shaila. You're on mute.
Thank you for your question, and thanks for Hexagon. Thanks to Hexagon to invite me. First of all, that is the most important fact in renal cases. Already, Madam told a lot. So we can manage through the diet, such as urea and creatinine, but continuous follow-up is most important because how the patient intake protein, how much patient intake protein in a household pattern, that not be measured in his house. When the patient came to us, when the nitrogen balance is counted, then we can decide how much protein we can calculate for him, and through the diet and through the reports, through the parameter of urea and creatinine, we can manage it. And it's also help with the doctor or treating physician or nephrologist.
Ma'am, would you like to add anything, Zandathan?
Sorry?
Your perspective from
Yeah. So basically, for controlling uremia, absolutely right, Ms. Shaila has said, we really need to see the nutritional status of the patient and then decide on the calorie and the protein requirement. So to reduce the uremic toxins, basically taking adequate amount of protein, but good quality protein. That's also one thing that we need to emphasize. Better quality protein is going to be utilized better, generate lesser uremic toxins, and the patient is also going to feel well. So that's very important that you need to focus, because predominantly, at least in India, when we have patients, they are more of vegetarian patients. So you need to understand the type of protein also that they are eating. The biological value of the protein, if you enhance, the uremic toxins can be reduced further. That's very important.
Thank you so much.
Such as the first class protein, fish protein and egg protein.
Yeah, so the quality of the protein is what matters in the end. So Ms. Sunita, as protein is important for children of growing age, and they also require, so salt is also a good, important source of iodine for these children, which is required for mental growth as well. So in patients with nephrotic syndrome, particularly pediatric patients, how do we ensure the right amount of salt and protein intake and ensure that their growth and development is not hampered?
So just like in CKD, we have stages. All nephrotic syndrome is not the same. Basically, you have steroid-dependent nephrotic syndrome, where the child is responding to the steroids that are being given to the child, and the disease as such is controlled, very well controlled. So in such children, you may not have to go overboard and restrict salt at all, because they are not having frequent flares when the steroids are being used. So they don't have any edema and asarca. So for them, it would be only the additional salts and the unhealthy foods, the sources from the unhealthy foods that have to be eliminated. But then in the steroid-resistant type of nephrotic syndrome, where the child is not responding to any steroids and the child ends up with frequent infections and lapses, that you see the child hospitalized with edema and infection, that is where salt restriction has to be applied, if depending upon the amount of food the child is eating. Generally, in these conditions, when the child is admitted, the intake will be poor. So you look at how much the child is taking in the entire day, and then apply your salt restrictions so that the edema is controlled. So anywhere between 3 to 4 grams may be necessary. Sometimes if there is too much anasarca, 2 grams may be necessary. So, but overall, if the child is eating only 2 small meals, then the entire 2 small meals may not necessarily be very bland, because that's just the 2 or 3 grams will go into those 2 meals that the child is eating. So case-based determination of salt restriction in this steroid-resistant group is important to bring down the edema and anasarca.
Thank you so much. So again, reiterating the point, individualizing and assessing the case on a case-by-case basis is very, very important. This brings me to a question for Ms. Shamim, who has worked in the community setting with children who are malnourished. So, Ms. Shamim, what are some of the renal insufficiencies that you see in malnourished patients in the community setting that you have worked in? Are you there, Ms. Shamim? Are you able to hear me?
Yeah, she's there.
Yeah.
Yes, yes, please.
Yeah.
So for most of these malnourished children, the renal insufficiencies we can observe, generally we can observe both in children and adults. One is the PEM, the protein energy malnutrition or wasting. The wasting is mostly in children, and the micronutrient deficiency. Yes, that is one of the renal insufficiency we can observe. And in most cases, these two, both the PEM and the micronutrient deficiency, leads to stunted growth in children prior to decreased appetite, nutrient intake, metabolic imbalances, and some other dialysis-related abnormalities. Then the other I can say that we can observe is inflammation. So the inflammation normally contributes to the defense mechanisms in organisms. However, if it is prolonged, it leads to adverse consequences. That is the decline in appetite, muscle and fat wasting, then atherosclerosis. This is mainly in adults, but for the children, we normally have the stunted growth, which is caused due to decreased appetite and nutrient intake. Yes.
Yeah. So in such a situation, it would be really important to first try and correct the, energy deficiency is also very, very much prevalent in these malnourished children, and therefore correcting the entire dietary intake itself becomes very important. And then in many times, if the renal condition is not progressed, the kids will usually recover and they will not really face any severe complications as such. So I'm going to take a couple of questions. They are pretty straightforward questions, but I think we'll quickly, because there are a lot of questions and I don't want to take them offline. So I'll just quickly go around the panel. What is the right source of protein in kidney stage 3 patients? Any of you who would like to take this?
I think that as per the preference of the patient, you have to give them the choices for the protein. There is nothing like a right source of protein. So probably for vegetarian, using a cereal pulse combination or dairy in limited amount is fine. For non-vegetarian, if the phosphorus is not a problem, small portion of meat, white meat and egg whites can be used. So there is no per se any particular source which is good. I would say whatever the patient is comfortable, you should balance out the diet and give the protein source.
Thank you, ma'am. Yeah, I think any of you again, is there any diet restrictions for AKI with severe hepatitis?
So again, AKI with severe hepatitis, there should be not any much restriction. You need to feed the person well. You need to know what has caused it. Probably these are acute elements that can be treated on its own. You just need to feed the person well, give the right nutritional as well as the medical therapy to the person so that he recovers faster. So feed the person very well. That's very important.
There are plenty of questions on what protein, what kind of protein to be given, so first class or second class protein. Is there really something about how much of first class and how much of second class protein that needs to be given for renal patients? Or would it need to be entirely a first class protein?
So it is not so. What we have been practicing is at least 50% should be high biological value. 50% can be of a mixed quality one. So even if you're doing that much, I think your patient is going to do well. Others can add to this, please.
Yeah. So basically, just now, a few minutes ago, we were addressing how to control BUN, BUN, the blood urea nitrogen. So here, Zamrud very clearly said that, you know, the kind of protein matters. That's the high biological value. A good quality protein gets better assimilated, leaving very little waste, so that it can turn out as BUN. So that's very important. So if you actually look at a very average Indian diet, if you mix and match the cereal proteins and then a little bit of egg whites and animal protein, basically it should be a mix of all these where they are getting all kinds of proteins from the lentil sources, from the eggs and from the lean meat. But only thing again would be to probably quantify it based on their stage of CKD. That would just matter.
Yeah. Ma'am, do you want to add something?
No.
Yeah. Okay.
I was just saying the same. Oh, sorry.
Yeah.
This got clicked.
Yeah. So, Ms. Yovani, this question is for you. Do you see an increasing prevalence of kidney stones in your setup? And if yes, what do you think could be the causative reasons for the same?
Yes, my answer to this question is yes, especially for the Mauritian market. We are seeing an increase in the prevalence of kidney stones, and it is a bit worldwide. When we try to look at different studies which has been done on kidney stones and its prevalence, yes, it is increasing. But to be honest with you, it is in Mauritius, we don't have any specific studies that has been done. And in my private practice, I haven't really seen someone like, suffering from renal problem coming with the kidney stone issue. But there's lots of patients not suffering from any particular renal disease that are suffering from kidney stones. And the causes that I will suggest, and I will be more than happy to have others intervene on this question, it's basically the lifestyle changes, because we are having lots of people with, obesity, and especially those who are really like gym addict and using all kind of supplements, which kind of put a pressure on the kidney. And this is one of the causes. And again, we need to have more studies on this to be able to say that, yes, this is a leading cause. But if you try to go into the physiological changes that happen when you are taking all kind of drinks, maybe rich in certain specific amount of minerals and things like that, it does put a pressure on your kidney, because lots of people, they might be having a kidney that's not really performing at its best, and they are not aware of it. They don't have any symptoms, and if they kind of put all kind of pressure on that poor kidney, definitely there will be issue afterwards. So yeah, that's my point on this. But if others have anything to add, most welcome. Any particular studies which you have come across in your particular region, it would be nice to share.
Yeah, so I would like to know the perspective from India, and since we have Ms. Shaila from Bangladesh or Ms. Sharmin from Uganda, I would like to know your perspective on this as well.
I
Are you
see a
there?
lot of people
Yeah.
with kidney stones here because we work in a kidney specific hospital. So basically, now in the recent practice, what I see is people have moved from whole grain or wholesome based diets into more processed diets. So the amount of processed foods in everybody's meal diet regularly has increased. So there is lack of fiber. So when there is enough fiber in your diet, so much of the salts get kind of bound to the excess fiber and get eliminated in the gut. But when the diet is extremely processed and refined, the amount of absorption of all these salts increase. So that's one major thing we see, especially the youngsters. So many of them staying out of home in metropolitan cities. They don't live with the family, they live outside the family. So they don't eat a fiber-rich diet. They eat a very processed diet with a lot of food additives in it that adds to it. Just not fiber, lack of fiber, but the food chemicals, and also heavy use of carbonated beverages. That also increases. Then the amount of salt in the diet also. Again, processed food means more amount of sodium in the diet, which precipitates calcium stones. So these things we see very regularly.
Ma'am, do you want to add anything?
Yeah, absolutely. What Sunita said is correct. And again, today, what Ms. Ivana said about the protein supplements, irrational use of supplements, which is contributing not only to the protein content, but also to the oxalate content of the diet. And again, not proper hydration. That's another thing that is very important. If people dehydrate with the sugary beverages, they are not hydrating themselves well. So basically, these are some of the leading problems that is leading to the increased incidence of kidney stones, and probably which further causes injury to the kidney, which when people may progress towards kidney failure. That's very important. So you need to have a balanced diet, adequate hydration, adequate amount of fiber in the diet. That's very important. And again, today, if you see, WHO recommends an intake of 5 grams of 5 to 6 grams of salt for normal people. Okay, and if you actually we try to do a little study on our own to see that what is the actual salt content, we found that around 15 to 16 grams of salt people are eating on day-to-day basis. So if your salt intake is also so high, you're not hydrating yourself well, you're not eating the right type of food, leading to other lifestyle diseases. Renal stones is also one of the lifestyle.
So, ma'am, you see a lot of literatures, particularly, in media, so in on newspaper or on social media, you see a lot of promotion for flavored waters or barley water, cranberry juice for reducing the incidence of stones.
Yeah.
What is your take on that?
So hydration is important. Okay, my take is that sometimes people don't like to drink only water. So probably if you have to hydrate your person with 2 liters, 1 liter as water and 1 liter in the form of flavor water, but these are not sugary flavors. Of course, that's very important. Talking a very important thing that you highlighted was the cranberry juice. There are papers which show that to prevent urinary tract infection, cranberry juice given early in the morning is very good, but it has to be unsweetened. Today, what you get in the market is sugary, loaded with sugar. So probably the benefit you do not get. Again, barley water, again, it's basically hydration, I would say. I recently saw a patient with kidney stones who cannot drink water. He doesn't like water. So probably if you just put little dhania leaves or the coriander leaves and you just put little lime to his water and you give him, he finished the full 1 liter bottle. I said, what's the problem? But giving those type of flavors which are not going to add to the calorie content, you can hydrate the person well, there is no problem to use these. But yes, cranberry juice has come up a long way, which shows benefit in urinary tract infections, and I think that is the reason today many people use the unsweetened cranberry juice, or probably even dehydrated cranberries where you soak and you can use it to prevent urinary tract infections.
Thank you, ma'am. So since we are on the question of hydration, when we have kidney patients, we see edema in these patients. And there's one question, as to how do we go about calculating the dry weight for these patients? It's a pretty basic question, but very important because we have a lot of students who are attending today as well. So how do we calculate the dry weight for these kidney patients? And do we then restrict fluids? How do we decide how much fluid to give to these patients?
Ideally, calculation of dry weights, there are some formulas which are there, but I was just discussing this point with our nephrology team. And it was like, to find out the edema, you can have grading of the edema seen by the nephrologist. But per se, they don't favor use of any formularies. So that is the reason when we do nutritional calculations, we do not use the actual weight of the patient. We use ideal body weight of the patient to do our calculations. And of course, when you see edema, you are seeing visibly when there is anasarca or pitting edema, then definitely there is an indication that you need to restrict the fluid. For fluid calculation in these patients, we use previous day's urine output plus 500. Okay, this is the way we calculate in kidney patients the fluid requirement. And salt prescription again vary depending upon the degree of edema and blood pressure values. If somebody has a high blood pressure, which is, or he's already on medications, then again our salt prescriptions would differ. I would say I would start from 0 to 5 grams of salt. Okay, and sometimes we may use normal salts also. That's why I said 5 grams. In some patients, you may not find any edema. So mind you, this is one of the metabolic change complication that you don't see in all the patients. But yes, you do see it in majority of the chronic kidney disease patients. They have some degree of edema, fluid retention, and high blood pressure. So your prescriptions need to be individualized. You do not have any fixed formula. At least I don't use it. If others are there, please, you can add to it.
Would you like to add anything else?
Yeah, actually, I agree with Zamrut. We don't use any formulas to calculate the fluid intake for a patient, irrespective of the degree of edema that the patient is on. Basically, the urine output is an indicator as to how much fluids that the patient can take. That is one point. And then if the patient is initiated on dialysis, basically hemodialysis, to be very frank, you wait for a couple of days when the till the dry weight is estimated by the nephrologist in the dialysis unit, where the fluid is removed to a considerable extent, where the patient is more stable, the BP is more stable, where they determine the dry weight. So that will give us an indication of the dry weight. But otherwise, for a patient who's on conservative end-stage renal disease, where they do come in with edema, look at the urine output to guide you for the fluid intake and calculate the ideal body weight. And if the patient is, sorry about that. If the patient has been following up with you, you will definitely have his file and his earlier body weight when he was not having any edema. So these are the indicators that you have to look for instead of using a formula, because most of the the population, most of these formula are based on the population studies, and in India we don't have very accurate height and weight formulations for the population.
Yeah.
So just to add, the patients who are on dialysis, in the machine itself, they have something which is known as a hematocrit, which they measure, and they know what is the hydration level for the patient. So ideally, based on that, the doctors normally make a prescription of the dry weight. So of course, I don't know in all units whether this is used. So that level actually decides what is the hydration level, and based on that. Now you can use body composition analysis, and many times we do try to see the dry weight of the patients. But again, those equipments may not be available in all centers. So probably we try, and for dialysis population, whatever the doctors calculate and give us, we normally use. Otherwise, in chronic kidney disease, I think urine output plus 500 should be the fluid allowance that we normally give our patients.
Right. Okay. So that brings me to another section of kidney disease. That's when there are a lot of questions on kidney transplant, and when patients are due for a transplant, they undergo a thorough assessment for fitness for surgery. From the nutrition point of view, also it's important to do a thorough nutritional assessment of the patient. Would the patient still have the similar restrictions post-transplant? Can they eat all the food without any restriction post-surgery? What are some of the tools that you use in your practice? So I would like to to know that from all of you in your setting, because each of you come from a different setting as such. So I think with you, Ms. Sunita, please.
Yeah, basically, when the patient is taken up for transplant, the patient is on dialysis. So most of the units use either a simple SGA, the subjective global assessment tool, or the malnutrition inflammation score. Either one of that is a validated tool for hemodialysis patients based on their unit. What are the blood tests that are done in their unit? They choose one of these, SGA or MIS. So since the patient is already on dialysis and where the protein intake has to be very high, the patient is assessed as per the requirements of dialysis. So just before dialysis, of course, the protein energy adequacy of the patient is assessed, the electrolyte balance and the fluid balance is looked into. Now, when you take a patient for renal transplant, from the time of surgery, you have to look at the nutritional requirement in two segments. One is immediately after surgery, where you treat the patient like a surgical patient. The situation can be dynamic. The protein requirement will be higher. And the electrolytes may change every day based on the patient's condition, soon after the surgery, transplantation. And the fluid output is increasing or improving, or looking at that to meet the fluid requirement of the patient. Given that everything goes right, the patient has a very good urine output, and you have to meet the output and give excess of fluids. In the long term, when you're sending the patient home, because the patient is on immunosuppressants and steroids, you look at the patient with to be having a certain amount of risk of cardiovascular diseases. And you have to look at the patient not developing new onset diabetes after transplantation if the patient is not a diabetic already. So those aspects of nutritional care have to be managed. Weight management, protein intake again post 1 month after the transplantation comes down. It need not be very high. The guidelines say 0.8 grams per kg body weight is what is the protein requirement in the long-term post-transplant patient. So those things have to be taken care of. Good kind of fats and avoiding refined sugars to prevent diabetes, and this kind of factors go into the long-term diet management.
Yeah, thank you. Ms. Giovanni, do you have something to share from your experience in your setting?
Yes, I'm waiting to share from my side. Here in Mauritius, we just started the kidney transplantation. It's something really new. And since the beginning, I think it was implemented last year. And we did like only 9 transplantations till now and 9 successful ones. And again, this is something I have to work into because they don't have a dietitian on board with them to assist the patient. So they are managing the doctors on their own. And something I believe we have to do here, because we have lots of diabetic and most of our renal patients are diabetic patients. So definitely, I think the sugar, the glucose level will have to be managed properly before the surgery and even just immediately after the surgery, because this will definitely define a lot and have a huge impact on the surgery. Yeah, so for us here, it's like a big thing to do. We have lots of things to do.
That's great. Thank you so much, Ms. Giovanni. Samrat ma'am, do you want to share your experience from the transplant unit?
So basically, I agree with what Sunita said, but one thing that we really need to keep in mind is that 25% of type 2 diabetics develop chronic kidney disease and they reach end-stage kidney disease. And again, the remainder of the chronic kidney disease patient, almost 30%, which come from the hypertensive background, who have the etiological factors, hypertension, also develop NODAT, that is new onset of diabetes after transplant, because of the immunosuppressive medicines which are used for them. So if you're looking at the post-transplant, you need to work with these people pre-transplant, rightly as Sunita said. Even when they are on the dialysis and when they are planning for transplant, you need to start counseling them about a diabetic low-fat diet, adequate in calories and adequate in proteins. And again, The moment they stabilize, initially you treat them like surgical people, how you treat a surgical patient. But here you need to pay attention. In surgical patients, that much of fluid and electrolyte challenge is not seen. What you see in the transplant, kidney transplant patients. So you have to have an eye on those parameters. 1 month post-transplant, between 1 to 3 months, again you treat them like chronic kidney disease patients because they have a single functioning kidney. If it is your native own kidney, you can survive, live very well with a single kidney. But since it's a transplant kidney and people are on medications, you need to reduce the protein intake between 0.8 to 1 gram of protein. Okay, that's very important for this population. And it's more so like a diabetic low fat diet if you're asking in the long run. Because if you see Indian population, the protein intake for our population ranges from 0.6 to 1 gram of protein. So that's very important. But again, one factor that you really need to focus is the sterile diet for these populations. You need to follow a sterile diet in most of the cases for the first year post-transplant. That's very important.
Thank you so much for that, ma'am. One of the mention that each of you did was about removing the husk from the grain in order to reduce the phosphorus content. So there's one question from the participants as to how do we then look at the fiber content, because there's restriction on fruits, there's restriction on the vegetables that the patient can eat. So how do we ensure that the fiber content is met or fiber requirements are met for the patient?
That's a very good question, actually. We always have this challenge of meeting the fiber in a patient who has to be restricted on the phosphorus and potassium. And most often they also have constipation. So, and then we know that there is a certain element of gut health involved in CKD. We have so many studies now coming up with CKD and gut health. So it is a challenge, I agree. So what we do in our unit is, I'm sure most of you, Zamrud, will also agree with me. We have a list of low potassium, low phosphorus, high fiber foods like from the vegetable sources. And also, you don't have to really use refined cereal. You just have to eliminate one level of bran. Maybe, for example, if I have to tell you in terms of food, maybe dalia is not okay, but atta is still okay. It still has fiber. So I'm not saying that you should use maida. So that's how you manage it. So you try to include a lot of low potassium vegetables and tell the patient to have it liberally. So again, when you counsel the patient, you have to be very clear as to what the patient requires. And hence, you have to make it a point, drive it home that they have to eat more of that, more of food from that segment, which has very medium amount of potassium and phosphorus.
Would you like to add anything, ma'am?
Yes, she's absolutely right. See, you can use the low potassium ones, or probably even if you're leaching and you're using the high potassium vegetables, that is also fine. We are okay with that. So we really need to feed the person well. The process that you do for leaching to reduce the sodium content, potassium content, phosphorus content is going to be useful to the patient. Now, I was just scanning through the questions and I saw somebody asking what is the degree of sodium and potassium that you leach when you boil. Well, it also depends on the amount of water that you use, the size of the vegetable that you cut and then you expose it, the surface area that you are exposing, the amount of water, the amount of time you are exposing that food.
Whether the lid is on or not.
So yeah. So again, if I say that you are going to leach this much, I will not be right. That's why we teach the leaching process to everybody. But when we are doing that in our calculations, we only make a reduction of 20 to 40%. And we try and emphasize on low potassium fruits and vegetables. See, even when I spoke about the fruit, I never said no fruit. Even if your potassium is high, you can easily use 150 grams of fruit, the low potassium fruit a day. And vegetables, you can easily use half a kilo. Your fiber content would easily come. And as Sunita has rightly said, see, in this case, millets may not be used. Millets are more coarser, so the potassium content may be higher. But again, what you are using in limited portions, it's possible to use. You miss it with your dietitian, do your calculations, you can incorporate all food groups in limited portions. That's what we have to train our patients. They don't have to be deprived of anything, but the portion sizes needs to be spoken to them. And that is why again and again I say there is no renal diet. Your diet needs to be specified in proportion or as per the requirement of your patient. The diet needs to be individualized. No two patients are same. Even if two people have the same amount of creatinine, the same value of potassium, their diet habits are different. Their genetic makeup is different. You need to make your prescriptions accordingly.
Absolutely. Actually, the way each person metabolizes the food will be so different that the amount of potassium and phosphorus absorbed will be different. And having more fiber has one more benefit, because of which we actually go towards a higher fiber. Because when they eat a good amount of fiber, the absorption of potassium phosphorus also reduces. So that advantage is there.
Correct.
Yeah.
Miss Yovani, you want to
Miss
add?
Yovani wanted to add,
If I can add, Ms. Patel summed up everything so well. And exactly, we don't have a renal diet, but we can say that we can have a renal friendly diet. And it's a lot about education, because it's really troublesome for the patient. And instead of complicating their life, and if we come forward to educate them about the low potassium food, about the high potassium food, and how they can do to reduce it, this is what will help them in the long run. You see, it's a combination of all this will definitely help them.
Yeah, thank you so much for that. So a lot of individualization is what I think the theme that's coming out of this discussion. There is one very interesting question that I saw in the Q&A box. A lot of these, there are some researchers that say that, patients with renal involvement or kidney patients are usually obese, and that's protective towards cardiovascular disease. So when you have renal patients, how much emphasis do you put on lifestyle and exercise in your counseling, in your day-to-day life, in your day-to-day practice?
I think that's very important. Today, all the diseases that start, especially when you're talking of chronic kidney disease, if you see the cycle, it starts with obesity, leading to lifestyle other diseases, and which end with you're reaching your kidney problems. So basically, when you're talking about diabetics, they are obviously type 2 diabetes, which ends up with chronic kidney disease. So definitely obesity you need to keep in mind. But when you're emphasizing, you need to give them healthy lifestyle options. Here we are looking at healthy lifestyle, good nutrition. That's very important for us to give to our patients. That's what I think. Others can add to this.
Yeah. Would you like to add, Ms.
Yeah, I do agree. Actually, obesity, there are so many papers which show that obesity is one of the independent risk factors for CKD. So when there is no diabetes or not very uncontrolled hypertension, if the patient is obese, so one of the primary goals of nutrition therapy would be to bring down the weight so that the disease process can be controlled. So essentially, just as Zamrud said, there is no renal diet. It's a renal-friendly diet, as Ms. Yovani very rightly put it. So it's a healthy, we should always start from the point of a healthy diet. Underlying theme here is basically to start with a healthy diet, a cardiovascular friendly diet, and a diet which is more going to push you towards a more ideal weight. So start with that, and then look at the other renal parameters, which you may have to tweak a little here and there. So that helps.
Yeah, that's right. Thank you so much for that. A lot of the participants are also asking questions about, is there really a need for a supplement in renal patients? Okay. So what conditions in kidney patients would warrant the use of supplement? And if at all, when you're selecting a supplement, what are the parameters would you look for in selecting the supplement?
So basically, if
you use those in your practice, yeah.
So if your patient is eating well, you may not use a supplement. But most of the kidney patients don't eat well. They have deficiencies of micronutrients, and then probably using a renal specific supplement, which is adequate in calories but lower in proteins, lower in electrolytes, may be a need. Many times people get admitted at our hospital, but we find that their intakes are poor. So probably we do use supplementation. We are not saying no. And we use renal specific supplementation. because the electrolyte content you don't have to worry about. So if your patient is a chronic kidney disease patient, maybe the low protein supplements we may use. And if your patient is on renal replacement therapy, then probably the high protein supplements which are available you can use. So it is not that you cannot use supplementation. You again over here, the same thing applies, that you need to individualize as per the need of your patient. So sometimes we do use these, and if our patient feels better, it's always good. The diet may not be providing, like we spoke of leaching. Many times when we leach, the patients don't like the flavor of that food. It's very common. So when they don't like the flavor, automatically the intakes drop. Then what do? How do you get your requirement? You're not reaching your nutritional targets. Then the better option is to use a supplement. What's the harm? There's no harm, but yes, you need to make you do your actual assessments. That's very important. You do your assessment. Based on your assessment, you plan your therapy. That's important. I don't see anything wrong by using the supplements for these patients. Again, many people are flavor conscious. They don't want particular flavor, so you have a variety available today. So probably you can use, again, the forms are available. You have powder, you have biscuits, you have bars, whatever is our patient is comfortable, you can use that. And you make the person eat well. See, you have to understand that patients having kidney problems do not eat well. So if they are not able to eat well, using support, even at times we use it like, the last resort, frankly. Where in the hospital, the whole day we see what they have eaten. And then in the end of the day, we give them the remainder balance. At least we try to catch up for little nutrition, and we try to give them at the end of the day that supplement. We do that many times. Even sometimes in the night we are not able to give, we try to give it in the morning. That previously the patient had compromised nutrition, so today we add that much. It's easy for the patient and for you, and you're reaching your targets of your calorie and protein. That's important.
So again, in this case, ma'am, a regular evaluation would be important. It would not be like the patient is always on
Yes.
supplement. You would want to decide how the case progresses.
Correct.
Would you like to add anything, Ms. Sunita, Yogini?
Yeah. Basically, can I go ahead?
Yeah, please.
Yeah. So in stable patients, as Amrut said, as such, they have very poor, so many of them have poor intake and they may require supplement at the end of the day. But then more so when you come to patients who are metabolically unstable and who have some infection or who are metabolically unstable, who have got admitted for a critical condition where, of course, giving a oral nutrition supplement or enteral nutrition supplement becomes the best thing, basically, because their intake will be very poor and their demand will be very high. So just if the patient is already on dialysis, it increases the requirement. And superimposed on that, if the patient is having some infection, then absolutely the intake increases. So even if the patient is eating moderately, because of the high demands, then you may have to definitely give a supplement, add a supplement to the patient's diet. So during hospitalizations, if there is an underlying infection, then definitely enteral nutrition helps, oral nutrition supplement helps.
Ms. Yogini, would you like to add anything to this?
Yes, in line with what Ms. Sunita just said, if there is a real need, then yes, I'll definitely add a supplement. But if I see that the patient is being well nourished, like let us say it is just a renal patient not on dialysis, if you can work with them to promote like a healthy eating and get them to better understand how to deal with the choices, then I'll go for this one as first line. If we want to say dietary therapeutic changes. But then if there is a need, yes, I do add, especially because it's really challenging. You see, a renal-friendly diet is not that easy. Oftentimes, as Ms. Patel said, the patient will lose taste, the food is not that tasty. So just to play it safe, we can add it to make sure they are getting the essential micronutrients.
Yeah, so judicious use would be something that would of supplements would be very important, so that it's safe and it's used for the with the right intentions. That would be very important. I remember when I talk about whenever I see this question, often dialysis patients are in for dialysis for 4 hours, and on their commute back home, a lot of, when you look at the remote areas, on the commute back home, they usually do not have a healthier option to eat. And then they would eat a fried snack or, a packet food, which would be high in sodium. So in such situations, I think use of supplement would definitely help. And of course, we need to look at meeting the gaps. If the patient is eating well, obviously there wouldn't be a need, but if the patient is not, then look at meeting the gaps in the requirement of the patient. Yeah. So yeah.
Maybe not forgetting that we have very many supplements in the market, so we should always take precaution of what type of supplement you are giving prior to how long it has been in the market and the manufacturer's history, because mostly in Uganda we have very many supplements which are not legit. So as well as we are happy to use the supplements we are giving to the patients, because they depend on our decision, we always have to take precaution on the type of supplement. Yes.
Thank you. That's very important. I think you pointed out, and there are a lot of regulatory bodies that will kind of tell you about the safety of that particular supplement, whether what is the heavy metal content, which is again a predisposing factor for renal conditions. So it's important to understand whether it's coming from a safe source as well. I'm going to take one last question before we wind up for today. Just give me a second. Yeah, there's this question that many of the participants have asked. Ma'am, you spoke about flavoring the food so that, patients, you can decrease the salt intake. So there's a question on, when you use tomato flavor, would that really be a concern, and how much of potassium it would really add to the diet? Because all flavors might not work with every patient. How do you go about that?
So when I showed you the flavors in my slide, I mentioned that you need to work closely with the patient. You need to know the electrolytes of the patient, and you need to give the prescriptions of even these substitutes that we use. It is not that they can use unlimited amounts. Okay, these also needs to be measured and given. Now, if I am looking at cinnamon powder or mustard powder for that matter, a pinch is enough to flavor a vati of vegetable. I have personally used it. That's why I'm confidently talking to you like that. But yes, you need to calculate whatever you are giving. So if I know that my patient is using 10 grams of amchur powder, a pinch of mustard powder, a pinch of cinnamon powder, maybe half teaspoon of lemon juice in the whole day, I'm fine with that, because I have accounted for that potassium that would come from those sources. Okay. And again, all patients of chronic kidney disease do not require potassium restriction. Hyperkalemia is present in few. Many a times, your diet may not be responsible for that, but they are given some particular medicines which would add to the potassium content. So you need to also understand what are the sources that are used. So you need to have a little insight into the drugs, the ACE and the ARBs, or the diuretics which are used in kidney patients, which may contribute to the potassium content. So if your patient is on these, and if I use unlimited portions of these adjuncts in the diet, then there could be a challenge. So whenever we are planning anything for our patients, the patient and the caretaker both need to be educated about what we are talking, why we are using some things, and what is the portion sizes. See, it's very important to give education to the patient. Nutrition education is very important for the patient and the caregivers. Only then they will be able to do justice to the diet prescriptions that you give. Can I give you a simple example? It has happened actually with me. I wrote a prescription to a patient where I said, eat one fruit a day. Okay. This was a chronic kidney disease patient. He didn't have any potassium challenge. I wrote one fruit a day without specifying the size of the fruit, without specifying the grammage that the person has to eat. This gentleman ate one watermelon for 7 days, and he had hyperkalemia. He was into fluid overload. So yes. So you need to write your prescriptions well, and you need to explain those prescriptions very well to your patient and the caregiver who's going to give food to that patient. That's very important. So even when I'm quoting these flavors that needs to be used, how much has to be given, in what recipe, what blends well, has to be explained to the patient. And also you need to account for the electrolytes that are going to come from these substances. That's very important.
Also, it would be important where these flavors are coming from, because a lot of the bottled flavors that you have in the market usually
Yes.
tend to be high in sodium.
Yes.
So they would have a lot of salt being added to it
Yeah.
as a flavoring agent.
So
So
I
that
have,
needs to
yeah,
be
I have evaluated this also because I use a lot of dry mango powder. So there are few brands in the Indian market where you read the label, it categorically shows you that each brand, the sodium content is between 10 to 15 milligrams per 100 grams, and the potassium is about 30 to 35 milligrams per 100 grams. So if the content is so low of these brands, so what is important for me to educate my patient to read the label? When I train them to read the label well, automatically they will pick these foods. And the moment they are going to pick, we are not going to have miships. That's very important.
Ma'am, since you mentioned about nutrition education, there is also another question as to how do you ensure compliance in these patients? And I think I would let each of you have the last word on this, that when there is restriction, how do you ensure compliance in your patients? So I think I'll start with Ms. Sunita today.
Yeah.
Thank you. Basically, we all as nutritionists have been trained in the art of counseling. And as we go through our journey during with the experience, we actually hone the skills of counseling a patient. Now, most of the time, most of the senior nutritionists will agree with me. Within the first 10 minutes of seeing the patient, you understand whether they are compliant, whether they are the kind who are going to listen to you, absolutely, or they're the ones who are going to go home and have their own say. So with this, the first thing is the counseling comes with experience. So with that, when there is a lot of restriction to the patient, what best you could do is make the patient and the caregivers, the family, understand the reason why we want them to restrict this. It's not just that, okay, you can have only 3/4 teaspoon of salt. Okay, you cannot eat this. But then if you really want them not to eat that and you know that it is going to harm them, you have to explain why it is going to hurt them, why they should not be eating it. Most of the patients are intelligent enough to understand the etiology or the causes why these things are being said to them. So that's one important point. And then you have to take your time. Most of the time, renal counselings take a lot longer time than the regular counselings, because you have to explain these things. So you have to have the patience and the time, because you may be doing it again and again and again. And so you know it, and many a times you take it for granted. But then you should remember that the person sitting opposite to you is going through this for the first time and they don't know. So you have to be very patient with them. Knowing a little background about their cultural habits, their family eating pattern, which part of the country they come from, where they come from, and their family routine, whether they are a nuclear family, whether they are the joint family. All this helps us to curate the diet for them. So these are some of the points on a broad scale that I would look at. Of course, assessments and other things which we routinely do will follow next.
Thank you so much for that. Ms. Yogini, your experience.
Yes, I agree totally with what Ms. Sunita said. Exactly, as dietitian, when we are being trained to work as a dietitian, counseling, it is a huge part, understanding the people sitting in front of you, psychology and all. It's really important. And I think, like, if I have to summarize this, it's basically the trust. You should be able, as a dietitian, to make your client trust you, because when that person trusts you, but then whatever you will ask that person to do, he will try his level best to implement it. And education, when you educate them instead of just imposing on them, this is what will make a huge difference. So we really need to get that trust and make sure that we empower our patient to be able to cope. Yeah.
Thank you, Ms. Yogini. I think Ms. Shaila has just joined us. If you're able to unmute, would you like to share your experience? about how you ensure compliance in your patients with respect to the restrictions?
Yes, I would say that just always have a rampant relationship with the patient and the caregiver, and always do not dictate the restrictions you're opposing to them. Just always make them feel comfortable, let them share with you, let it be a sharing session rather than you dictating the restriction, and clearly explain each restriction to them, even if it takes a week. Just give them their time such that they clearly understand and both sides can achieve. Yes, thank you so much.
Thank you so much, Ms. Shameen. Namrata, would you like to have the last word?
Well, I agree with all of them that counseling is very important. Planning the diets close to their ethnic patterns and their family patterns is very important, and educating them that why we are restricting this and why we are adding something to the diet, that's very important. So today in this era where we believe that we are talking of science, food science, we need to explain, we need to give justification for everything, and the moment you are able to do that, your patient's compliance becomes good. One more thing that I have realized that, in the long run, when I've been doing with my patients, is to ask them to record their food diaries. Many of my patients themselves have picked food which was told to them not to eat and they have eaten, and they themselves mark it and they come, when they come for their. So that really helps in our compliance. So good counseling, a diet pattern close to their family pattern, and again maintaining the records. This is something that is very important for our patients to get good compliance.
Thank you so much, ma'am. So just to summarize today's session, we started where renal diets used to be extremely low in protein. People would be scared to give protein, to give fruits, vegetables in the diet. And today we understand the recent guidelines suggest that it's important to individually assess each patient, understand what stage of renal failure the patient is in, and accordingly individualize the requirements for protein, electrolytes, fluids, etc. It's also important to work with the patient, understand their dietary habits, what's available to the patient in terms of the resources, and then accordingly decide whether a supplement would be required, whether any adjuncts would be required, flavoring agents would be required for the patient. So thank you so much for such a fruitful discussion on this topic. Let me just quickly make an announcement for next week before we wind up. So next week, our session number 4 is going to be on semi-elemental and polymeric diets for critically ill patients. And our speaker for that day is Dr. Anaga Palekar from BY Nair Hospital in Mumbai. So I request all of you to join at 6:50 on next Wednesday. Please note that the session will only begin at 7 o'clock sharp. So you will be able to join the session at 7 o'clock itself, and you would be in the waiting area on Zoom until the session is started. Thank you so much for joining us here. And I'm just quickly going to post the feedback link as well so that each of you could. Yeah. Okay, I can't find the feedback link, so I'm going to email that link to all of you. Thank you so much for joining me. Have a good night.